Hello everyone and welcome to the EUPATI webinar on cross-border healthcare in the European Union. My name is Jana Popova and I'm the EUPATI Patient Engagement Training Coordinator. Today I'm going to be your moderator on this webinar on cross-border healthcare. EUPATI is a multi-stakeholder public-private partnership which runs successful education programs for the capacity and capability of patients and patient representatives to understand the medicine research and development processes. Recently, we focused on the European Union cross-border healthcare framework because it is essential in providing patients with access to treatment. Despite its critical nature, this framework still has low awareness among different stakeholders and it is difficult for implementation. The aim of this webinar is to promote a clear understanding of the European Union cross-border healthcare framework and to provide a clear overview of the patient's journey when they are seeking a treatment abroad. Next slide, please. Before we continue with the main topic of our webinar, let us briefly introduce a few housekeeping rules. The first one is that all microphones will be in mute. This webinar will be recorded and shared publicly in the EUPATI YouTube channel. Also, please use the Q&A box for questions to our wonderful panelists and the chat box for additional comments. Please ask your questions to the panelists in the Q&A box because we are going to monitor only the Q&A box. We may not have time to answer all your questions, but we will make sure that we are going to incorporate them as a main outcome of this webinar. Also, you can upload the question if you have the same in mind. There is no need for repetition. You have unlimited option to upload questions. And finally, but definitely not at least, we would like to encourage you to ask your questions and to share your feedback. Let's make this webinar interesting and engaging together. Next slide, please. Now we would like to ask you two main questions about cross-border healthcare. And I think now the polls should be launched. And we are going to ask you the first question, which is how would you rate your knowledge about the EU cross-border healthcare framework? Please share your knowledge, share your feedback, and click the answers. You have options for multiple answers. So we are really looking forward to receiving your feedback. I think we can close the poll now. 42% of you shared that they have poor knowledge about the EU cross-border healthcare framework, and 29% of you shared that they have acceptable knowledge. So thank you so much. We also have some people with good or very good knowledge, which is really good. And hopefully this webinar is going to be useful for everyone. And thank you so much for sharing your feedback. Now, we would like to ask you one more question before we continue with our wonderful speakers. And our next question is, how prepared do you feel about undertaking the journey to seek treatment abroad? Again, you have options for multiple answers. So please share your feedback and share your thoughts here. And also you can put some comments in the chat box as well. So unfortunately, 46% of you shared that they don't feel prepared at all, and 30% shared that they feel slightly prepared to undertake this journey. So hopefully this is going to change after this webinar. Thank you so much for sharing your feedback. And now we would like to go to the next slide, please. And we're not going to waste more time, and we're going to introduce you to our wonderful speakers today. These are Professor Stefaan Callens from the Catholic University at Leven, Sara Perez, patient representative and ePAG member, Oriana de Sousa, patient expert and EUPATI Fellow, Michela Gabaldo, Head Alliance Management and Regulatory Affairs at Fondazione Telethon in Italy, and Corinna Hartrampf, Senior Project Manager at International Association of Mutual Benefit Societies. Next slide, please. Welcome to all our wonderful speakers, and this is the order of their appearance. Next slide, please. Now, without wasting more time, it is our pleasure to introduce the keynote speaker of the day, Professor Stefaan Callens. He is a lawyer in Brussels and a professor health law at Catholic University in Leven. Professor Callens is a member of the Royal Academy of Medicine of Belgium. Stefaan often conducts research on patient rights, competition in healthcare, and pharmaceutical law. He publishes regularly on the organization of the healthcare and on e-health. He was one of the authors of the toolbox Cross-Border Care that was distributed by the European Commission in 2020. Professor Callens, welcome. Please turn on your camera and the floor is yours.
Thank you. I hope you can hear me. So I will talk a little bit about the legal framework of cross-border care, and I will have specific attention also to the issue of rare diseases. Next slide, please. They asked me to give an overview of the history of cross-border healthcare and also the content of cross-border healthcare from a legal viewpoint. And if you look at the Treaty on the Functioning of the European Union, then you should have a look at Article 168 to understand the issue and the problem also of cross-border healthcare. And next slide, please. If you look at Articles 168, it's a very long article, but it's mainly saying that the member states are very important, have an important power with regard to the organization of healthcare. And if the European Union wants to do something, it can only complement national policies. Next, please. So here you see in point 5 that, okay, the Commission and the European Union can intervene when there are, for example, pandemics like COVID, but always the issue is point 7. It's up to the member states to organize the delivery of health services and medical care. And European Union has to comply with that, has to respect with that. And so the question then is, if this is really the system we have for the moment, what can the European Union do? Don't they have any power to legislate anything regarding cross-border care? Well, they do have quite a lot of power with regard to healthcare. Next, please. If you look, for example, at the issue of the European semester, then we see that the importance of healthcare at the European level becomes very important. Next slide, please. In 2008, we had the banking crisis, and the European Union decided to monitor more closely the way how member states organize their society, their banking system, but also their healthcare system. And so each year, at the beginning of the year, in the first 6 months, the member states have to communicate to the Commission their plans for the future with regard to the economic policies and the budgetary policies. And at that time, the Commission will then look whether or not this is in conformity with the main objectives of the European Commission. Next slide, please. It's a whole process that takes 8 to 10 months. What we do see is that more and more the European Commission is looking at the policy of the member states in whether with regard to the way how they organize their healthcare. Are they using cheap medicines or good medicines? Are they using e-health and so on? And next slide, please. With regard to COVID, what we do see is that also member states were struggling with personnel, with the masks, with certain products, vaccines, and so on. And the Commission is now paying attention and is looking whether all these member states are able to combat pandemics, are able to have a very strong healthcare system. So even the organization of healthcare system is a national competence. Through the system of the European semester, the Commission has a very important impact more and more on healthcare and at the end also on cross-border care. Next slide, please. So here you see the reference to the COVID issue and the problem of the semester. It's a little bit more modified in view of the problems member states have, but I will not tackle that issue. Let's go to the next slide. And next to the semester, you also have the possibility to go to court or to ask a question as a lawyer, as a local court to the Court of Justice. And the Court of Justice will verify whether national rules are in conformity with the European principles and the European law. And the Court of Justice had already in the past decided in very important decisions on the free movement of goods, the free movement of services, the free movement of persons. And you do see here on this slide and also on the next one, the principle of free movement of goods. And at first sight, that has nothing to do with healthcare. But if you use it, for example, to buy medicinal products abroad, or to get reimbursement of certain medicinal products, then the issue of free movement of goods will be involved. And on the basis of these articles, the Court of Justice decided, for example, in the past, that medicinal products can be imported in parallel, but also they decided that the member states, if they decide on the reimbursement of medicinal products, they should do it in a very strict period of time. They cannot give a company a period of 1 or 2 years before answering a question regarding reimbursement. And so on the basis of this jurisprudence, the Commission finally enacted at the end of the 80s, in 89, a transparency directive, which is a very important directive because it's saying, okay, it's up to the member states to decide on reimbursement of medicinal products. But the way they do that should be in conformity with the Treaty of the Functioning of the European Union and should comply with the principle of free movement of goods. And you're hindering free movement of goods if some companies have to wait 2 or 3 years for an approval of reimbursement and others get a decision in 6 months. And so therefore, in the directive, it's imposed on the member states that they should make a decision in 180 days. I put a lot of attention to this directive because this might be very important in the case of rare diseases. If you want to go abroad and you need a lot of time before you get your approval, that may hinder the free movement of services. And that's the reason why I think that in parallel with what we saw for medicinal products, it must be possible that even at the EU level, a directive would impose on member states a strict period of time to make a decision. Next slide, please. So the right of establishment is important for healthcare professionals. It will allow them to go abroad, to see patients in other countries, but it will also allow them to have patients from foreign countries, from other member states, which might be important if you want to treat patients with rare diseases. And so next slide, please. On the basis of all these articles, including the freedom of services, next slide, please, we got important decisions of the Court of Justice. For example, the Cole decision whereby the father sent his daughter to a German dentist and he asked for reimbursement to his local sickness fund in Luxembourg. That was refused, and the argument was, we have our own dentist here, you cannot go to another one. And Decker, who was a friend of Cole, was also a lawyer who created this case to test the Luxembourg rules. He bought some glasses, specific glasses in Belgium, and asked again at the Luxembourg Sickness Fund to get a reimbursement, and that was again refused. And the Court of Justice said, well, next slide, please. In these two cases, the refusal to reimburse ambulatory care or to reimburse the goods, the lenses, this will hinder the free movement of goods or the free movement of services delivered by a dentist. And you don't have to be afraid of your social security system, because that was the main argument of the sickness funds in Luxembourg. They were saying, if we have to reimburse all these costs of care abroad, this will be problematic for our healthcare system. And the answer was, no, that's not the case, because you are just reimbursing the cost at the same level as you would do if they would go to a Luxembourg dentist. So you are only using your own national reimbursement scheme. So there is no problem with regard to financial problems of your social security system if someone goes abroad, comes back and asks for reimbursement. And then next slide, we also had the Smits and Peerboom cases that was referring to more expensive care, hospital care, with an overnight stay. And here the Court of Justice was a little bit more strict, saying, okay, it's quite normal that in this kind of case, the sickness funds refuse reimbursement at first sight because it's quite expensive. If everyone goes abroad and you invested in your own hospitals, but they are empty because people go abroad, and then you have to reimburse the costs of someone who is going abroad, that's problematic. So that's the reason why the court accepted that for care, whereby someone has to stay at least one night abroad. You can ask for an approval and it can be refused. However, the court said that if there are waiting lists and if it's really medically needed that you have this treatment, then you cannot refuse that patients go abroad, get the treatment, come back and ask again for reimbursement at the local prices. And so that was the jurisprudence of Cole and Decker, Smits and Peerboom, and later on some others. And it's on the basis of this kind of jurisprudence that we then got the famous Patient Rights and Cross-Border Care Directive. However, we had already at that time the Social Security regulations, and the Social Security regulations were created to allow, for example, some people to work in a neighboring country, and if they come sick, who would take care of that, who would reimburse the costs, and what if someone is living in Belgium and later on is going to Italy or Spain when he is retired and he gets sick, who will reimburse the costs? Or you go skiing in the Alps in France, for example, and you have an accident, who will reimburse that, according to which tariffs? All these issues were already very long regulated in what we still call the Social Security regulations. They were already revised, and there is again a project for revision again, but that's regulated through a regulation. So a regulation is a binding document that is applicable without having to implement with a national legislation. And the Cole and Decker cases were not based at all at a regulation, because here the patients, they didn't ask beforehand for consent of the sickness fund. They just went and they just asked reimbursement on the basis of the local tariffs, on the tariffs of the country where they were residing. Whereas under the regulation, you can go abroad and you can get reimbursement at the level of the prices applicable in the country of treatment. And that may be much more expensive than in your own country. And that's the reason why under the regulation, you always need a prior consent before you can go abroad and get reimbursement at the tariffs of the country of treatment. Next slide, please. I will not talk about the Charter of Fundamental Rights in view of the time. You can continue. Next slide. And so when we got the Patient Rights Directive, it was just to make sure that on the basis of the case law, Cole and Decker, Smits and Peerboom, we got a kind of a legal framework. And in the legal framework, the principle is normally you should apply the regulation. So you can go abroad, but you need prior consent. But if you want, you can also apply the directive. And then the directive is implementing the case law, Cole and Decker, and so on. Next slide. There are differences, as I said already, between the regulation and the Patient Rights Directive. The directive is focusing on, for example, healthcare providers. They have to inform patients about treatment options, about quality and care. There are the national contact points who has to give information to those who go abroad on the reimbursement of the treatment plan. And there are national contact points for incoming patients who have to give information on the criteria regarding quality of care and so on in the country where people want to be treated. Next slide, please. Important is that under the directive, the reimbursement will be done by the member state of affiliation, and the information about this should be given by the national contact point of the country where you are residing, where you are living. They have to give you the information in detail about the reimbursement before you go abroad. Next slide, please. Next slide, please. I will not discuss this for the moment. Let's have now a look at the two frameworks. As I said, the regulation exists already very long, was not used in the Cole and Decker cases. It's for scheduled treatment, but it may also be possible for unplanned care. You go skiing, you have an accident, and how will it be reimbursed? That's regulated by the regulation. But there are differences with the directive. For example, in the directive, you can go abroad, but you need upfront payment. You have to pay before, and then you come back to your sickness fund and ask for reimbursement. However, in some cases, for example, if you have an overnight stay or a risky treatment, it might be the case with certain rare diseases, you will need always, in principle, prior authorization of your sickness fund if you want to go abroad on the basis of the directive. That's not the case for ambulatory care, then you don't need at all a prior consent. If you want to go abroad on the regulation, you will always need prior authorization. The reason is the reimbursement will be on the basis of the tariffs in the country of treatment. That's not the case in the directive. In the directive, it's reimbursed on according to the rules where you are a member of the sickness fund. And another important difference between the regulation and the directive is that the directive applies to whatever type of care, provided it's reimbursed, but whether it's provided by a private hospital or a public hospital. If you want to go abroad under the regulation, then normally you can only go to public hospitals. There are some exceptions, but that's the main principle. Next slide, please. I think there are some other differences, but for the moment I will not discuss them. Maybe we can go on that during the discussion. But next slide, please. In view of the time that is going, just keep in mind that under the regulation, you can have, for example, treatment for long-term care. That's not the case with the directive. If you want to go under the directive and get reimbursement on the directive, long-term care is not covered. And so for rare diseases, if you want to go abroad under the regulation, it may be possible, but you need prior consent of your sickness fund. If it's not a long-term care program that you will receive for a rare disease, you can ask to apply the directive. But the problem with the directive is, okay, you can choose whatever hospital you want abroad, but you have to pay upfront, and it might be very expensive. And so maybe at this point, people are saying, should we not review the directive and see whether or not we can work like under the regulation, whereby actually the payment will be done by the sickness fund, and so no upfront payment by the patient. Next slide, please. There are some other topics under the directive. One I would just want to mention in a few seconds is the European Reference Network. It's a coordination voluntarily created of specialized centers all over Europe for very specific diseases, often rare diseases, whereby people, without moving themselves, by using telemedicine, have a look at patients and try to find treatment plans for them. It's not long created, a few years already, or only a few years, but I think this will be very important also for rare diseases. Next slide, please. So when we wrote the toolbox, and you can consult it by using this reference to the website, whether you are someone working for an agency or a national contact point, or whether you are a patient, please have a look at, and you want to go abroad, please have a look at this toolbox where you find very important information on the differences between directive and regulation. Next slide. It is unfortunately very, very complex. Especially the regulation is a very complex document because it depends from which countries you were living, where you worked, where you paid your social security contributions, where you live when you are retired, and so on. But with this kind of decision tree, if they would apply it through an app, it would be easy to go abroad. I will have to finish closely, I think, but maybe next slide. I would just want to let you know that we found in our study together with Securi that there are a few problems. The national contact points are not well known for patients. That's a pity. Next slide. The websites can be better, especially if you go abroad and you want to know what will it cost. And if you come to a country, you should need more specific information about the healthcare plans and the healthcare professionals. Next slide. What about the future? As you may know, we are there is a public consultation organized by the Commission regarding the directive. And next slide, the last slide, please. Is that possible? Yes, here we are. And so I think it would be good if by reviewing the directive, the Commission would try to impose more strict timelines for those member states who have to give prior authorization, for example, for expensive care, planned care, risky care. Or under the regulation, they're okay. They can regulate timelines. They did it for the medicinal products. They can do it for therapies for rare diseases also. Maybe we should review the need to provide upfront payment if you go under the directive abroad. And for the rest, I think member states are now promoting what we call local hospital networks. We should more and more promote supra-regional networks, and as we did already for specific diseases, European networks should be more promoted than they did in the past. That's my last suggestion I have for the future. Thank you for your attention.
Thank you, Professor Callens, for this really wonderful and interesting insight into the cross-border healthcare. Now it is time for our next speaker, Sara Perez. She's a bachelor in psychology, clinical and health. She has postgraduate training in cognitive neuropsychology and behavioral neurology, research methodology, public health, and gender perspective. Sara is a full professor of psychobiology at the University of Alcala. She is also a collaborating researcher at Roosevelt University, Chicago. Sara is a member of different scientific societies and working groups, including Spanish Rare Disease Federation, EURODIS, and ePAG. She is also EUPATI Fellow. Sara, welcome. The floor is yours.
Hi, hello everybody. Can you hear me well? I'm with my mobile, so sorry for the webcam. Well, thank you so much. I would like to speak with you to start the conversation about patients in this field in cross-border healthcare in rare disease with a short presentation. Next, please. Nowadays, cross-border healthcare for many patients is a new word. In rare disease, for example, is a new word. Well, we have to think that the active patient paradigm implies the constant updating, not only in words. We have to think about the concept and everything related with this concept and their implication for health to have the handle. Patients have to know about what does this mean, not only speak about cross-border healthcare. Next, please. Well, rare disease, we all know that patients are defined by many characteristics, such as the need for diagnosis, treatment, and information. And in many cases, patients have need to access health service outside their country for diagnosis, treatment, access to drugs. We all know about regulation. In last presentation, we talked about this. And we all know that European nationals have the right to seek planned healthcare in another country, European country. We all know that patients claim reimbursement for treatment for your national health system in our country, health insurance provider. Next, please. But also, we must know that it's a patient right. Well, we all are patients of something, and it's a right nowadays to give patient access to the safe and quality health care in another European country. And also, as Professor Stefaan says, foster cooperation between national healthcare providers, including in the field of rare disease. And nowadays, European Reference Network has this point. Next, please. Well, today I was supposed to talk about patient journey to seek and abroad. We all know many examples, not too many, but we all know some examples about that. We also can talk about how do we interact with healthcare provider, with a patient in another country. But with this short presentation, I prefer to talk about recommendation, what the patient needs, what is the real problem nowadays for patients in the field of rare disease, but for all the disease, really. In my experience as a patient representative, I would like to focus on the training in handling of this regulation. Not all the patients and not all the patient association knows about this word or this concept. Also, we think that the patient or the best recommendation is to think and to understand the patient journey as something global. Not only think about this is what I have to do in my country. This is my patient journey since the beginning of my disease, of my children's disease, to the end. We have to think about in a global point, and we have to think that to know about the regulation and what does this mean is to handle for the health of our patient. So this is the recommendation. This is what I want to put in the table: the training and the knowledge of the patient when we are talking about cross-border patients. So next, please. Thank you so much, and it's time for the next patient representative.
Thank you very much, Sara, for this interesting presentation. And it was really interesting to see your feedback about cross-border healthcare. Now, I would like to present our next speaker, Oriana de Sousa. Oriana is a psychologist and a 10-year rare cancer survivor. She self-advocated for her treatment and went through several hospitals in her country and abroad, focusing on finding a cure or best treatment that she could have. Oriana was the first patient of her type of cancer doing immunotherapy, which led to achieving a complete remission. She graduated from EUPATI and has been participating in several patient advisory boards from European projects dedicated to rare diseases and personalized medicine. Oriana also has been invited to different panels to emphasize the importance of patient engagement. Welcome, Oriana. Please turn on your camera and the floor is yours.
Hi, good afternoon. Thank you so much for the invitation to be here in this panel. And I would like also to greet the audience. So I will share briefly my experience as a rare cancer patient, chasing for my treatment across several countries in Europe. Next slide, please. So in 2011, I was diagnosed with small cell ovarian cancer, hypercalcemic type, which gives the acronym SCCOHT. And by the time I was only 22 years old and I was studying forensic psychology master, I had no previous experience with cancer in my family or rare diseases. So I had just basic concepts about cancer. Just to give you a quick overview about SCCOHT, against the other types of ovarian cancer we are used to know, this one is typical or is common in young patients. So it's like a pediatric one. And in 2011 was basically seen in patients with a mean age 23. Nowadays is a bit more, 24. And is considered the most aggressive type of ovarian cancer, characterized by the fast growth, recurrent relapses, and a chemo resistance, as well. Is also resistant to other treatments, and because it's resistant, gives these common relapses. And is also characterized by the mortality, especially It happens generally that patients don't have a treatment, so they relapse, and obviously after relapse, don't having a treatment, they passed away. And we have two types of this type of cancer. Can be hypercalcemic one or not. In my case was hypercalcemic, which means that it increased the calcium in the blood level, which is poison, and for that reason it speeds up the death, the possibility of death for the patient. So if you have this diagnosis, you are not just trying to stop the disease, but also to stop the calcium, and your time is passing. You need to speed up to find the treatment. So when I was diagnosed, I don't have any clue about a treatment to cure, and I start to looking for. So next slide, please. So in 2011, I was diagnosed in a Portuguese hospital of the National Health System, and I look for a new opinion in Spain. I was actually looking for immunotherapy because I learned about immunotherapy 1 year before my diagnosis. Because of other Portuguese patient with other type of cancer. But the doctor in Spain was really straight, telling me that my type of cancer would not respond to immunotherapy. So he actually had the same opinion that my Portuguese team. So I returned to Portugal and proceed. But later in 2012, I have my first relapse. And this time, my team in Portugal told me that they have just palliative treatment for me, and they would perform a surgery, but they were not confident enough that someone in the team would be skilled enough, or if they could actually done the surgery. But in this time, I just would like to emphasize that despite they don't know if they have enough skills to perform the surgery, they never told me that I could look for other place to treat myself, nor even they told me they will look for another team in Portugal or in the abroad. But I gave up on this hospital, and I went to Spain again, to the same hospital I was previously, and I ended up being operated there. Later, I was treated in Portugal in 2 different places, and in Spain, in Portugal to receive chemotherapy and radiotherapy. And unfortunately, in 2014, I had second and third relapses. And this time, I decided to do treatments that I never heard that other patients with my condition had experienced, like a radiosurgery and dendritic cells vaccines, which were actually, dendritic cells vaccine was the immunotherapy treatment I heard, and I did want to try in the past. And it seems this combination had helped me to don't have any progression of the disease for some months. But unfortunately, in 2015, I got a fourth relapse, and this time was a major relapse in all my abdomen. And my hospital in Portugal told me that they don't have anything more to offer me, just palliative care. But hopefully for me, I was in this clinic in Germany, and they already got a new drug for immunotherapy, which I learned after that possible in 2014 had been applied in Portugal to off-label for melanoma patients, and later in 2015 was applied in Portugal in trials for melanoma or lung cancer. So I was lucky to have this treatment in the right time in Germany, because it actually leads me to achieve complete remission, and I stopped the treatment in 2017 here in Portugal, and I'm not having disease since 2016. So the thing I would like to emphasize is that probably even later I wouldn't have this treatment in Portugal, because nobody would say this is something that would benefit me. Next slide, please. So I just want to summarize and highlight some aspects here. that basically when we got a diagnosis, we don't have any we cannot have any previous experience. We are struggling with the information, with our emotions. And if we have a life-threatening condition, we are also running in time. And basically we just have our healthcare system to guide us in telling us what to do and what are our rights. And for example, in my case, I didn't know about my rights. I never used this cross-border health legislation. I just was lucky enough to have the support of my family and in the research, as we've seen previously. The rare patients, when they have time, actually, they look for new solutions. And in a rare diseases, we should be aware that a lot of the times the science is not done yet. So we don't have evidence that somebody can tell us, okay, this patient should receive this treatment, because there is no evidence yet. So as patients, when we look for some treatments, we should be supported. And I believe that the autonomy of the patient should be supported. And if we have this health literacy to empower us, because we know that in Europe, health literacy in generally is average or low, and we could partnership with our health system, we probably will have our treatments faster and access to the right one. Next slide, please. Thank you so much for your attention, and everyone who want to make some questions, please be my guest.
Thank you so much, Oriana, for sharing your personal story. And now we would like to invite our next speaker, Michela Gabaldo. She's Head Alliance Management and Regulatory Affairs at Fondazione Telethon in Italy. Michela is an expert in regulatory affairs with more than 20 years experience in drug development. She's currently supporting the two internal scientific institutes in Italy, San Raffaele Telethon Institute for Gene Therapy in Milan and TIGEM in Naples. They provide global strategic direction in regulatory affairs for the progression of gene therapy, ex vivo and in vivo, and gene editing projects. In the last 5 years, Michela acquired an in-depth knowledge of the different legal frameworks leading to the EU cross-border patient access. Michela, it is a great pleasure to have you. Please turn on your camera and the floor is yours.
Thanks a lot. Good morning to everybody. I'm Michela Gabaldo. I'm the Head of Alliance Management and Regulatory Affairs. I would like to, I'm honored to have been invited to share our experience on the cross-border healthcare use. And I'm here today to share with you the first case that we have been experiencing on Strimvelis. Strimvelis is an ex vivo gene therapy. It's the first ex vivo gene therapy that has been registered in Europe. And it is registered for the treatment of an ultra-rare disease, is a severe combined immunodeficiency due to adenosine deaminase. The name is ADA-SCID. This therapy envisaged a very complex and articulated process leading to the hospitalization of the patient, to prepare the patient some weeks before the actual treatment act, and the manufacturing is done at an external manufacturing facility. So actually there is a selection of a subpopulation of hematopoietic stem cell that is isolated from the patient's own bone marrow. This subpopulation is enriched and then is transfected with the actual vector to correct the cells, which are then reinfused to the patient. So when the patient is reinfused with the cells, then he has to remain a few days in isolation, a few weeks, sorry, until it is recovered, and then he will have, after a few months, he will be able to come back to home and be monitored long-term at home. So the peculiarity of this product was that this was, and is still, a fresh product, so it's stable only for 6 hours, so up to the end of the manufacturing at the manufacturing facility. up to the end of the, from the end of the manufacturing up to the end of the infusion, we have only 6 hours. And so these, of course, were imposing a dramatic change on the paradigm on how we are used to manage the patient access. Because in the case of Strimvelis, being a fresh product, the patient have to travel because we could not move the drug. So here we had, at that time in 2016, we posed 2 questions. The main question was how to fund the treatment cost, so the cost for the drug and for the clinical treatment, for the clinical care, and how to support the families in moving. So we ran an in-depth analysis on the current European provision for the planned treatment abroad. And as Professor Callens have clearly stated before, we enter on the pros, we did analyze the pros and cons that would have in this specific case. So I'm speaking about a very innovative and high costly drug, how we could manage and give access to the patient, not only the Italian patient, of course, but patient from Europe that could be referred to our center in Milan. And then in parallel, of course, thanks to the partnership that we had at that time with the first leading company that registered this product, that was GlaxoSmithKline, we established a program that we call Just Like Home program, where we have a patient care unit dedicated, fully dedicated to the support of the patient and of his family in moving to Milan. So to come to the legal framework to receive the funding, to cover the funding, of course, we analyze the Social Security regulation and the directive, and also we analyze the bilateral agreement. For which I'm not going into the details that Professor Callens have already clarified and share, but I would like to focus on the main reason for why we decided that one versus the other one was the only possibility, the only path that could enable us treating the patient in Milan. And there was the reason was that, as Professor Callens have highlighted, to the Social Security regulation, the family has not to anticipate any money needed for the drug, not for the clinical cost. Provided, of course, that they receive a pre-authorized S2 form before traveling. And the treatment, the other important thing is that the treatment to seek the approval, the treatment has to be included in the treating country basket of care. Whereas under the directive, the patient would have to pay in advance the money, and then they would be reimbursed when back at home, always providing that they have received the approval before traveling. But the reimbursement, of course, would be only with against the tariff of the living country, not of the country where the treatment has been to be provided. And in this case, the treatment has to be included in the patient country of residence basket of care. So this is our experience. As I was saying, with the pre-approval S2 form, we are covering clinical service and drug cost according to the country of treatment tariff. And the experience that we have as per today with Strimvelis is that we had one case of pre-approval S2 form that was covering only the clinical cost in the approval setting. And then after that, we have 6 out of 17 patients referred from Europe, from countries like Germany, France, Switzerland, and Belgium, where we have been able to obtain a pre-approval covering in the commercial setting, both the clinical cost and the drug cost. And unfortunately, we have to report also cases where this process for the S2 form approval has not been completed or has not been approved. And here we have a case from Poland, one case from Belgium, one case from Switzerland, and one from Spain. And in this case, the approval has been too long that the patient was no more eligible, or due to the lack of clarity on the approval process, the family decided to have an alternative treatment option that was not ideal for the patient. We have also some experience also with LIMLD. So this is the second product that has been registered very recently, thanks to a partnership that we have with Orchard Therapeutics. The name is LIMLD. It has been received registered in Europe by the end of 2020. And in this case, we are still in the pre-approval setting, but 7 out of 41 patients that we have received the treatment as per today in the pre-approval setting, has used this route, the S2 route, to cover the clinical cost. Of course, in those cases, the drug were provided for free. But we are confident that we could use this framework for eventual patient that could be referred to our center as well, because the difference between Strimvelis and Limmeldi is that Strimvelis, of course, could not be moved, but we have seen that being an ultra-rare disease anyway, due to the rarity of the condition, it was not reasonable to think about that anyway the company would have to activate more center across Europe. With Limmeldi, of course, this is again an ultra-rare indication, and for ultra-rare indication, it is important that the patient is followed by clinicians that know very well the in-depth disease and are also qualified by the company to be able to manage all the logistics and the complexity behind the administration of this kind of therapy. So the key learning of the Strimvelis case was that, of course, as I was saying, the complex disease require highly specialized clinical competencies that may not be available in all the European countries. And in this case, the cross-border healthcare could be very helpful in give access to the patient affected by rare disease. Complex therapy require concentration of knowledge, and so there are specific logistic requirements, training and qualification that again could not be available in the European country. And moving patients across Europe, even if it's not ideal anyway, as we have seen also from the previous example, you know, if you have a clinician that are aware and know in depth that specific disease, it could be safer for the patient to move and more cost effectively if you are also helping the family moving. For sure, it could be safer for the patient to receive the treatment abroad. And for sure, there is a need for a centralized European approach to ensure a timely patient access, because what we are missing here again, and our experience is confirming this, is that there are no clarity on and harmonization on timelines and the procedure to obtain the approval of this treatment abroad. And I'm like to close by showing you this picture. This is the first baby that has been treated with Strimvelis in the commercial setting. This patient is a Syrian refugee living in Germany, and it was the first treatment that we did with a pre-approved S2 form. She is more than 4 years now in follow-up, and she is doing actually well. I would like to thank.
Thank you, Michela, for sharing your experience and your feedback about cross-border healthcare. Now it is a time for our next speaker, and this is Corinna Hartrampf. She's a senior project manager at IMI, International Association of Mutual Benefit Society. Corinna is in charge of the European affairs, including digital health policy, health system reforms in the different member states, and policies of mutual benefit societies. Previously, she was the head of the Brussels office of the German Medical Association. She also studied law in Berlin and completed her first state exam in 2004. From 2005 until 2007, she was trainee lawyer at the Supreme Regional Court in Berlin and passed the second state exam in 2007. She did a Master of Laws in Medical Law in Düsseldorf. Corinna, welcome. Please turn on your camera and the floor is yours.
Thank you very much, Jana. First of all, thank you very much for the invitation and the possibility to present the payer perspective and the cross-border healthcare journey. Next slide, please. I will first speak about the role of payers in the cross-border healthcare process. Then I will talk about the preferences and the recommendations to patients of health insurers. Then I speak about the experiences of health insurances with rare disease patients and recommendations to that journey. And then I will give you an overlook of AIM support to patients, tools, and resources. Next slide, please. So let me first shortly present our organization. AIM is an umbrella organization of statutory and complementary health insurers. We are based on the same values, which are democracy and solidarity, which means our members make no risk selection. We are not for profit, and we want to guarantee universal access to healthcare to all. We have 55 members in 28 member states, which means apart from the EU, we also have members in Africa and Latin America, and our members cover around 240 million insured people. Next slide, please. So the role of the payers in the cross-border healthcare process is to inform patients about the policies of, about the reimbursement of cross-border healthcare. As my previous speakers have pointed out, the legal framework is very complex. It's not really easy, and so it's also very difficult to explain to patients what kind of possibilities they have. We have already seen at European level, there's the coordination of social security systems, the regulations 883/2004 and 987/2009, as well as the cross-border healthcare directive, which reimburse in a very different way. In addition, there are also several projects at national level with neighboring countries. So if you take the region France, Belgium, Netherlands, and Germany, there are various projects. And for example, in Belgium, there also exist contracts between foreign stakeholders and hospitals between Belgium and the Netherlands. So you can see it's not even at European level, but even at national level, there are a lot of possibilities how to reimburse, and that all needs to explain to the patient. Next slide, please. When coming to our preferences and recommendations, we must say that health insurers and health mutuals in charge of compulsory health insurance always have favored the application of Regulation 883/2004 if it's possible. Why is that? We have already heard before, there is a maximum price security for the patient, and there is no patient in advance, because some treatments are very costly and not everybody can afford that. What is important also, we realize that patients still do not know about their rights, which we have seen at the polls at the beginning. So the information to patients needs to be continued, and patients are advised to proactively consult and engage with their mutual and health insurance fund, examine the possibilities, because they can tell the patients how they will be reimbursed and if they get reimbursed. Because we have seen, for example, under the directive, you only get it if it's in the basket of your home country. And there is a need from our point of view to secure that health insurance fund and health mutuals are more inclined to use the regulation. And if that is not possible, to get a minimum of reimbursement for the affiliates using the directive, for example, when it comes to treatment in private hospitals. And from our point of view, there's also a need to simplify the legal framework for patients and for professionals, because it is really complicated and it's really difficult to make it clear to the patients what their rights are. Next slide, please. Then there should be collaboration between public health bodies, health providers, and health insurance funds and their members to identify the hurdles and develop solutions, because there are still a lot of hurdles, and we still need to find the solutions, and one actor should not do it alone. Then proactively informing patients includes that health professionals should inform patients in advance whether there is a care abroad. And also they should always provide patients from another member state with a cost estimation before they use the healthcare. And the last, access to cross-border healthcare from our point of view cannot be seen separately anymore from telemedicine. But for that, we need regulation and the creation of a level playing field in Europe on providing digital solutions. Next slide, please. And then coming to the rare disease patients, of course, everything what I said for patients in general also counts for them. But what is special for rare disease patients, I think we have seen it already with the previous speakers, that rare diseases really sometimes need more the expertise from abroad for diagnosis or treatments, because it's not always possible on the spot or in all member states. So they're much more dependent on cross-border healthcare. Of course, what we saw as health insurance fund, the administrative procedure is very burdensome, and it's even more burdensome for rare diseases patients because it is more complicated, and also medicine is costly. And because they are expensive, the procedures of getting medicine reimbursed are harder than it is for medicines administered for a common disease. It's sad, but it is true, it is the case. Next slide, please. So AIM support to patients is, there's a need to simplify the legal framework for patients and for professionals. We're currently working on the evaluation we're helping with the evaluation of the directive, and we try to find solutions to do so regarding prior authorization and how to make procedures shorter, because it's true, our members agreed that sometimes they're too long, they could be shortened. We cannot stop to say that patients are advised to proactively consult and engage with their mutual and health insurance fund to examine the cross-border healthcare and what they get reimbursed, because it's not always the case. And also patients should know whether they have to pay in advance or whether they do not have to pay in advance, and where are the differences. And from our point of view, what I already mentioned, there is certainly a need to secure that, we advise to use the regulation and only the directive when it's not possible under the regulation. So for example, when there are treatment in private hospitals. And also what I said, telemedicine is very important in the cross-border healthcare context. And on that, we're working to make it possible that the reimbursement will work, because it is, in many times it is cheaper. I don't want to say that it should replace the contact with the physical contact with the doctor. That should always be the first goal. But some telemedicine could help, especially also for patients with rare diseases, because then they can stay on the spot, which they usually prefer. And when it's cheaper, then it's also, the procedures might be faster in some cases. Thank you very much.
Thank you very much, Corinna, and it was a real pleasure to hear your input and presentation. Now is the time to hear from you, the audience. In this section, we have a chance to discuss together with all the speakers what we have heard and learned so far. So I would like to welcome back all our wonderful speakers and to kindly ask them to turn on their cameras. And also I would like to encourage you, the audience, if you have any questions to our panelists, please put them in the Q&A box and we are going to provide you with an answer and discuss your questions. I think we have one question already, which was to Professor Callens. Let me open the Q&A box, and oh, I think the question is answered already, which is really good. But please keep your question here, put them in the chat box, in the Q&A box, and we are going to provide you with answers. And now I would like to ask Professor Callens, actually, I have a question for him as well. Having into consideration the different perspectives which were presented here, according to you, what is crucial for the proper implementation and development of the cross-border healthcare?
I think two things. First of all, the time frame in which health insurers are giving an answer to someone who wants to go abroad under the regulation should be short. And if this can be regulated at the EU level, I think that would be good. It would be good if for each country, a public health authority should decide in a very short period of time whether someone can or cannot go abroad and for reimbursed costs regarding treatment of rare diseases. The second issue, as already said also by Corinna, I think indeed telemedicine is important, but with regard to telemedicine, I think the Patient Rights Directive gives a very good, clear framework. It's saying that normally you have to do the care according to the rules of the country of treatment. But in case of telemedicine, there is an exception. It's provided that the care is done according to the rules of the country where the healthcare professional who is the tele expert is working. So in that case, he only has to adhere to his local rules and he can follow patients all over Europe without having to be authorized in all these countries. And I think this is a very important issue mentioned in the directive. I think through COVID, we will have seen in all member states the possibility to get reimbursement of consultations because it was often difficult to get in touch physically with a healthcare professional. I hope that even after COVID, we continue to do that. And this may help also patients suffering from rare diseases to get in touch at a distance with healthcare professionals, get reimbursement for this kind of consultation. This is a kind of an ambulatory care that should be reimbursed without any discussion. Even if you consult a healthcare professional abroad, you don't need any prior authorization for just a consultation, according to the directive.
Thank you. And I think we have a question from the audience as well. I'm not sure to who is this question, but maybe we could ask the panelists. So how to tackle the difficulties with getting prior approval needed for National Insurance Fund due to inadequate healthcare access, limitation for diagnostic procedures, and long waiting lists? So please, everyone who, I think maybe Corinna, this is something which you could answer this question.
Yeah, maybe we have discussed with our members themselves, and they agree that sometimes the prior authorization procedures are too long, and they're discussing themselves. So, for example, one of our members in Lithuania, they said it takes up to a month, and 10 days are only for audit questions, and they have to send it to a different authority. And these kind of things could definitely be shortened, so they are on it. And then there were even discussions in that sense, yeah, prior authorization, is that really necessary? Because some member states do not have it, and they don't have any problems with that. So that is also, it's in discussion. It should be further analyzed, but of course, these are all kind of things that takes time. And some of our members have said, yeah, we don't have it. And there was not an explosion of patients, because patients like to stay home. So it's not really that there will be a mass of patients coming into the country. But of course, it also needs to be analyzed, because you don't know, it depends on the country. Some countries are probably more favored to have healthcare than other countries. But these are kind of the possibilities we are certainly discussing, yes.
Thank you. And Michela, I saw before that you raised your hand. Would you like to comment what we have heard so far, or do you have any questions?
If possible, I would like to complement the response from Professor Callens in the chat box, because I think that this is a key point. We receive frequently this kind of request because we are managing both clinical trial and treatment abroad under commercial setting. And I would like to clarify that for clinical trial in particular, of course, all the costs associated to movement of the patient and treatment, so the cost of the drug and also the clinical cost are under the responsibility of the sponsor, who is opening this clinical trial to study this investigational medicinal product, because this is an investigational medicinal product. So the example that I took was a commercial setting where the rules that the Professor Callens has clearly clarified are applicable, and under exceptional circumstances, early access. This means when you have completed the package and you are waiting to have the product commercially available, so you can use under exceptional circumstances this framework, but this is not the current one. So for sure, for clinical trial is sponsored. Sorry if I came back, but I thought that is a very important point, and we receive more than once these kind of questions.
Thank you. Indeed, it is important to clarify that and to discuss this. So it's really great to have you all here today. And now we have another question. Probably, Sara, you may take this. It is, how important is the role of the European reference networks in cross-border healthcare?
Yeah, well, thank you for this question. Now in rare diseases, the European network are focusing on in this topic. For example, for new applicants, for the last call, for new applicants, healthcare provider to be in the network, in a specific network, there was a specific criterion to get for the healthcare provider who is applying relate with this cross-border patient. They have to have a plan, or they have to have some kind of experience in this kind of patient with these needs and these cross-border patient. So it's very important. And this is why in this training in EUPATI, we are focusing on, this is the real work for patients nowadays in Europe. But the European network are focusing in this topic. Yeah.
Thank you. It is indeed very important. And I would like to encourage the audience to keep asking their questions and to put them in the Q&A box. And Oriana, I would like to come back to you and to thank you for sharing your personal story. And at the same time, I would like to ask you, how do you think cross-border healthcare has changed in the last few years? Are you aware of any positive examples in this field?
Yeah. After my case, some years after my case, actually was in 2018 or 19, I met a girl with a rare cancer too, another type of rare cancer, and she indeed had a cross-border experience, and she got support from our country. But she also have a lot of trouble to get it. She was fighting for it some months, and she ended up getting the support because she found some other patients with their condition who already have the treatment, and that is something that I was trying to emphasize with my presentation, that sometimes we don't have even months. I didn't explain very well myself about hypercalcemia, but hypercalcemia can put a patient in coma in some weeks, and also even can't prevent patient to have a surgery, as it was my case, and I was needing urgent surgery when I found my cancer, and I couldn't have it because hypercalcemia could not make me survive to a surgery. So anytime I had a relapse, my calcium was raising, so I had no time. So comparing to this girl, we have both. I have rare cancers, and obviously, if she had get her treatment earlier, it would be better for her. But in this case, in her case, for example, she could have expected 10 months. In my case, it wouldn't be possible at all. So this evaluation, it really depends on the disease. So having time to evaluate 1 month can be too much for some patients. And as I told previously, if we don't have any evidence of disease, any evidence of science for the disease, we couldn't ask for the doctor to evaluate, because he will say that, okay, this is not for you, as they told me. Nowadays, some other patients are having the same treatment as I did and having good results, but they are based on my case and the others that had after me. But when it was with me, I didn't have any results of a rare cancer on immunotherapy, nor my type or other rare cancers. Nowadays, there are trials even with immunotherapy for rare cancers.
Thank you. Yes, and indeed the things are changing, which is at some point good. And there is a question in the chat box, but also we would like to remind the attendees that there is also a link posted to the toolbox. And the question is where to find more information on the topic. Maybe Professor Callens, we could start with you.
If you look at the website that I gave you, you have actually two parts. One is for the national contact points, another one is for the patients. And there they have a manual, they have a leaflet. It takes you maybe 10-15 minutes to have an overview of the website, but it's a very good website in all European languages, published by the Commission, that may help patients who want to go abroad. And normally they should receive already the information from their own national contact point, who will inform them about reimbursement. And as also Corinna said, normally they will propose to go under the regulation. But in some cases, if the treatment is not so expensive, or if it's just a consultation, I would not hesitate to verify also the rules regarding reimbursement on the basis of the directive. Okay, you have to pay upfront, but it may be a less amount if it's only a consultation at a distance. And you don't need prior authorization for, it's only when you are dealing with risky treatment, overnight stay,
planned care that you need prior authorization under the directive. So I agree that for many long-term programs you need regulation, but I'm also aware of the fact that for certain treatment plans it must be possible to use the directive. And it would be good if after the evaluation process, the directive is becoming much more modern and be more harmonized in view of what we have already under the regulation.
Thank you. And we have another question in the box. Maybe it is about Corinna and Michela at the same time. So we are going to start with Michela and then Corinna, maybe she could add also her input. And the question is, how do you measure the quality of life of chronic patients? Is this incorporated into the cost calculation of Foundation Telethon or into the IMI work program? Michela, first.
I type on the chat box, but thanks for the opportunity to clarify better. Of course, we are a hospital, so Fondazione Telethon has a joint venture with Sara Perez Hospital where the treatment are administered. So the hospital is exposing the cost of the drug, but not defining the cost. So the cost is defined by AIFA, in this case, that is the Italian HTA body. And we are applying the list price to the cost that we request. And of course, we add the clinical costs. So the cost associated to the long period of the patient stay in the hospital. So this means hospitalization, additional drugs that the patient may need, exams, whatever is needed depending on the kind of drug. Of course, quality of life is not, so we are not running any HTE assessment as a hospital. And so this is not included.
Corinna, would you like to add something?
Yeah, maybe because I see is it added into the AIM working program? We're the umbrella organization of the health insurance fund. We're not the health insurance fund as such. So our organization is not reimbursing, it's the health insurance fund, our members. And of course, I'm sure if when they do the cost calculation of the reimbursement, they will also take other factors into account. But that you really have to ask the health insurance fund who deal with that and who are the experts on that.
Thank you for the clarification. And another question, which is actually coming from one of the speakers, Oriana, she would like to ask how the patient gets the information about their rights. And maybe, Oriana, you could clarify what you mean and also who would like to ask.
Okay, thank you, Jana. Yeah, it's because obviously we are now here speaking about the cross-border legislation, etc., and we are now aware of it. But when a patient starts their experience as patient and is diagnosed, we don't know anything about it, and some doctors may know, but even so, they never speak about it to the patient. So when patient is trying to survive and digest everything, how they could know about it. Thinking about me and other patients I knew, we were just running and trying to survive. We are not trying to look for legislation. We were actually looking for trials and treatments, and not even knowing that we could find some laws, because even the thing is that sometimes it's real hard being patient, and sometimes we see the doors shutting in your face. Even if you go to another hospital in your country, you can see that then your main team or your prior team don't want to treat you anymore. This is a reality. So how can we as patients know everything, and how can we really know that the healthcare team is saying everything we could know, because they are those who are guiding us, and for the most patients who don't have health literacy, how can they protect themselves? Thank you.
Maybe I can say something. I think that was I was trying to explain a little bit during my presentation, because we had also a lot of discussion with the Commission. The national contact points give the information, but I think patients maybe do not know that there are national contact points. I mean, we know the directive, we know the regulation, but a patient who doesn't deal with it, how does he know? So I think I was pointing out that also there should be the doctors, the professionals, and also our members as health insurance funds and health mutuals, they should know about it. And also doctors, they should give the information right away. They should know about the directive regulations, about the European reference networks, and they should give the information to the patient directly and tell them immediately. So it's not only the national contact point, but I think also other actors in the healthcare field should know more about it and give the information right away.
Thank you. And Michela, would you like to add something?
Yeah, I would like just to share our experience. Of course, I'm speaking about a very innovative drug, not available everywhere, but actually what happened was that we were pointing out all the referring physicians that contacted us to seek an advice on the eligibility of the patient for the treatment before the accessibility, of course. And when they have confirmed that the patient may be eligible for the treatment, that is, then often is our treating physician that has been trained on the legal framework and on the path in general that provide the suggestion on the fact that there is a national contact point, because according to our experience, sometimes the referring physicians are neither aware themselves that there is a national contact point because they have never experienced cross-border need before. And then we found very, very useful the manual and the checklist and the document the European Commission has recently, in the last few years, published. So we offered them this package and we help them navigating their own question when they are applying for the path. So it's a joint effort, but of course, this is there is no black and white. Unfortunately, our current experience is that ERN is involved in the diagnosis, but still at the moment, as they are set, they are not involved in the prescription. And so directly, they are not involved in the cross-border as well. But this is our experience.
Thank you. And now actually I have a question to all of you. And I would like to kindly ask you, all of you, to share what was the main outcome for you from this webinar with one word, please. Professor Callens, let's start with you.
We need to make sure that the existence of the legislation is presented to healthcare organizations, healthcare providers, and patient organizations. And through these organizations, I hope that the finally patient will get the information he needs.
Thank you. Sara, would you like to go next?
Yeah, for me, in my opinion, maybe improve the knowledge about this kind of patient or this kind of regulation, and to think about the quality of life related with cross-border patient and regulation, and as an outcome, always the quality of life of the patient.
Oriana?
I think it's a bit about reinforce the idea that we should be aware of the legislation and make and speak louder about it, and maybe reframe and use the guidelines and be close to the healthcare system and reinforce this importance and establish different pathways to look to rare diseases.
Thank you, Michela.
My last, of course, I'm fully in line with in terms of urgency for awareness and especially clarity on processes and timeline for the approval, because patients often do not have time to wait, as Oriana were saying, but also in our case, sometimes having a delay of 2 to 3 months in the approval means that the patient is no more eligible for a potentially life-threatening treatment. So for us, it's key. I would like to stress the point that ERN should enlarge the scope and be involved at the European level to facilitate this cross-border movement, if needed, of course. So we're not advocating for everything, but when there are no alternative or there are no center anywhere, and the patient is in life-threatening condition, we need to help them. They are, I mean, ideally, they could help.
Thank you. And Corinna?
Yeah, like my previous speakers already said, improve the information to patients and not only rely on the national contact points, but also educate the healthcare professionals, the health mutuals and health insurance fund, so that everybody tries to improve. And of course, try to shorten the administrative burden and the procedures as much as possible, and maybe even think to make the legal framework a little bit more easier and facilitate it a little bit.
Thank you. Thank you to all our wonderful speakers. And now it is the time for the final poll before we leave the webinar. And I would kindly ask my colleagues to launch the poll. We have two questions for you. And the first one is, how would you rate your knowledge about the EU cross-border healthcare framework now after you attend this webinar? Please share your feedback, and let's see if this webinar really was helpful for you, because this was our main aim, and I believe this was the main aim of all speakers. I see that some people already responded, and we're maybe a few seconds for other people to respond. And you can see the results that after this webinar, 50% of the attendees shared that they have acceptable knowledge about EU cross-border healthcare, which we believe is something very important. And we have one more question to our attendees. And it is the next question: how prepared do you feel about undertaking the journey to seek treatment abroad now, after the webinar? Reflect on what we have heard so far and on everything we have discussed and we have commented. And hopefully we were helpful for you. And of course, you can always contact us for further clarification or for any questions that you may have through any of the speakers. And now we have people who feel, actually it's a tie, we have people who feel slightly prepared and quite prepared after they attend the webinar to seek treatment abroad, which we believe is something very important. Thank you. So now let's stop sharing the polls, and I would like to thank all our speakers and all the audience for attending this webinar. Also, we would like to highlight that this webinar was recorded and it is going to be uploaded in the EUPATI YouTube channel. And we would like to also highlight that we believe that this is an important topic, and we will continue to follow the development of cross-border healthcare. So let's work together on this, and let's disseminate the value of cross-border healthcare. Thank you to all our wonderful speakers, to the audience, and to everyone in the team. And I wish you a very nice afternoon, and hopefully to see you soon after the summer. Have a great afternoon. Bye-bye.